polyps are growths that grow on the surface of the bowel, many a time the large bowel. And polyps take different forms. The word polyp is just a description of tissue, meaning a bunch of cells that have started going a bit crazy. And if we allow them to go very crazy, they will eventually change into a cancer. So by removing a polyp, we are preventing a cancer. And this is the reason why we have bowel cancer screening programs. And we urge patients to go, if they have a change in bowel habit, to go and see the doctors to get a colonoscopy, because this can save lives. This really can save lives. This is an eminently preventable disease, colon cancer. So a polyp, as I was saying, is a bunch of abnormal cells that can grow in many forms. It can grow like this, like a tree on a trunk. They can grow like sort of a bush. So we call these sessile or semi-pedunculated polyp, and they can be very flat and subtle. And the removal technique depends on the morphology, meaning the shape and size of the polyp. So the commonest form of polypectomy, as it was previously described, initially described rather, is by, if this is the stalk and this is the polyp, one puts a loop around the stalk of the polyp, and with electrocautery, we slice through the stalk and we remove the polyp. Of course, there can be a bit of bleeding, so we use certain solutions to inject the stalk to reduce that. And we can also place some clips which eventually fall off, the tiny ones. Everything is magnified on the screen, so the tiny ones, and these fall off without much ado. And we, of course, send the polyp for a microscopic examination. We call it histopathology or histology, for us to get the result. Because if there was a cancer inside that polyp, we wish to know that this has been entirely cured and the patient doesn't need any further investigation. We, of course, follow patients up if they have polyps removed. If we have larger lesions or a semi-pedunculated bush-like polyp or a very flat lesion, then we tend to use a different technique, which is called EMR, or endoscopic mucosal resection. And what does that entail? So endoscopic mucosal resection, if the polyp is growing on this surface, we inject underneath the surface, because fortunately, although the bowel wall is really thin, we are able to separate the layers by injecting underneath it. And like so, we lift the polyp away from the remainder of the bowel wall. And like so, using a snare, we are able to take this out either in one piece or several pieces, if that is indicated. Then there are certain types of polyps where we have suspicion, because when we look at a polyp, a lesion, the words are interchangeable, we can interrogate it by looking at it with different types of light. So nowadays our endoscopes are very high definition. They even have zoom incorporated into them, and we can interrogate the surface. And by looking at the markings, we can tell whether there's a high suspicion for cancer already happening, or something we call high-grade dysplasia, which is a step before cancer happening. And if that is the case, then we can't take it out in pieces. And if it is too big for what we call EMR, that I've explained earlier, using a snare, we use a very specialized technique, which I do. I've learned this in Japan, called endoscopic submucosal dissection, ESD. And this entails lifting the polyp away from the rest of the wall, like before, injecting underneath it. But instead of using a snare, a loop-like instrument, we tend to use a small knife, and we start cutting the lining and then dive under the polyp and cut underneath it into the submucosal space, and then eventually we cut around it. And that is called endoscopic submucosal dissection, or ESD. And ESD has the benefit of giving the pathologist, the person looking, the doctor, the specialized doctor looking at it under the microscope, a piece which is one. Okay, so no, the polyp has not been cut into different pieces. It is one polyp with a surrounding area of normal lining, mucosa, and that allows the pathologist to cut it up serially and look at it under the microscope. And if there is a cancer, they can give us a definitive answer whether there is need for further intervention, for further treatment, or whether this has been cured. So polypectomy and the resection of polyps saves lives by preventing cancers. And I urge you to have your colonoscopy if you're due. So, of course, before a polypectomy or a polyp removal, we will have a consultation whereby the potential benefits, the benefits and potential risks are explained in detail. Of course, like any other procedure, there are potential risks, and these include making a tiny tear in the bowel called a perforation, or bleeding, or an infection. But many a time, these are very small risks. They hover around 1 in 500 to up to about 2% in the larger lesions, which involve the endoscopic submucosal dissection procedure. Even if there is a tear in the bowel, many a time we're able to close it with clips endoscopically, so it avoids the need for operation. We obviously may have to give some antibiotics sometimes. And if there is a bit of discomfort afterwards, we may have to observe a bit with antibiotics. But many a time, it is very straightforward and safe. And the benefits by far outweigh any risk. Because remember that if we leave a polyp in place, the chances are that over time, this will change into a cancer with great detriment to the patient. So this is what is discussed at the pre-procedural consultation. When one has the procedure, during the procedure, we usually do this under sedation, so the patient is rather comfortable. We may or may not have an anesthetist to give deeper sedation if the procedure is going to take longer, but the patient will be comfortable, and we use certain techniques to make it even more comfortable. And it depends on what type of polyp it is, how big it is, as regards to how long it will take. But usually the procedure can take between 15 minutes to about an hour or so. And if it's a very big lesion, sometimes even longer. But everything is done under controlled conditions with the safety and comfort of the patient in mind. Where in expert hands, polypectomy is a very safe and effective procedure, and many a time we're able to remove most polyps if it is indicated to remove them endoscopically. Of course, some polyps, after we look at them and interrogate them with special lights and dyes, if we see that this is too advanced, then of course there is no indication to remove it endoscopically, because the patient would need an operation. And in that case, we take biopsies and we mark the polyp with a tattoo of sterile carbon particles for it to be removed in a minimally invasive surgical way, keyhole surgery, laparoscopic surgery. But that is the minority of cases. In the vast majority, we are able to remove these polyps effectively and safely. So after polypectomy, during polypectomy, there's always some risks, of course. As I explained, these risks are small, so they hover between 1 in 500 to about 2%, depending on the technique used and the type of polyp it is. And if we have a tear in the bowel, many a time we're able to close it there and then endoscopically. Of course, there are cases where the tear happens later, a delayed perforation, but it is very, very unlikely nowadays because we take measures to avoid that. And in rare circumstances, there can be some bleeding after the procedure, which can happen even up to 2 weeks later. So instructions are given to the patient to make contact if there is any bleeding. But each case is dealt with on its own merits, and we take every measure we can to avoid any complications. So a polypectomy, or an endoscopic removal of a polyp, is a safe procedure. The complication rates hover between 1 in 500 to about 2%. As mentioned, there is a small risk of having a tear in the bowel, which many a time can be closed endoscopically during the procedure, or a risk of bleeding, which can happen even up to 2 weeks later. Many a time, these are not life-threatening situations and can be dealt with endoscopically as well. And it is really not a painful procedure. And if there is any discomfort, this is, of course, dealt with using sedation, which we use for all our procedures, many a time with an anesthetist present, just to be able to give the deeper sedation. It depends on the size of the polyp, so it can take 15 minutes, it can take 30 minutes, sometimes it can take longer if we're doing an endoscopic submucosal dissection. But the patient's safety and comfort are always borne in mind and dealt with to ensure that the patient is receiving optimal care. After the procedure, many a time there are no symptoms, no discomfort, but if there is a bit of discomfort, because sometimes we can irritate the wall of the bowel during the procedure, that is dealt with by the right approach using analgesics and, if need be, antibiotics. Sometimes we observe patients overnight or a bit longer if need be, and very rarely is there any need for other interventions. But yes, so in effect, it is a very safe and effective procedure which prevents the occurrence of cancer in those abnormal cells we call polyps.